Thanks, Tracy. So thank you for that wonderful introduction. Myself and Kathy will be presenting today, but I also want to acknowledge other members of the research team, Michelle Magnuson, who is joining us in the audience, and Sherry Dick and Michelle Cleland, who weren't able to join us today, as well as Morgana Malian. I want to acknowledge her work in terms of helping us devise the survey that was used for this research study. I also want to acknowledge that Winnipeg and Brandon are on shared territory between the Dakota Iote, Anishinaabe, and national homelands of the Red River Métis. Today, many other Indigenous people call Winnipeg and Brandon their home, and acknowledging the plants, the animals, the people who share their history, traditions on these lands, and the water in the area that were deeply influential, and we're grateful to gather on these lands today. So we're talking today about those who experience disability, and disability has been viewed and defined in many different ways. So for example, under the lens of the medical model, which is a very common model to use in nursing, psychiatric nursing, disability is considered an individual problem defined by illness, injury, ailment, or inability. However, an alternative to the medical model is the social model of disability. The social model focuses on barriers that limit or prevent participation in society, or in this case, education. According to the social model, it's environments and practices that should be adapted to reduce barriers and improve access for all. So this model differs from the medical model, where disability is considered an individual problem, where the person is required to adapt or change. And it's also been found that the medical model contributes to stigma and discrimination for those who experience disabilities. Academic institutions in Canada have reported an increase of numbers of students who self-identify with disabilities over the past 20 years. Due to this increase, the need for student accommodations have grown. However, accessibility services have become strained and under-resourced. So although we have more students self-identifying with disabilities, the personnel in accessibility services hasn't necessarily increased, which is why a lot of institutions are reporting that they're under-resourced. Furthermore, nursing faculty have expressed uncertainty regarding ways to manage the growing number of accommodation requests and how to implement accommodations in a manner that's both fair and equitable. So what are accommodations? So reasonable accommodations refer to adjustments or modifications made within academia to better ensure equal opportunity for students with a diagnosed and documented disability. And accommodation is a different way of completing a task to allow students to work more efficiently. So the intention is not to lower the playing field or compromise the integrity of the program. The purpose is to do things in a different way to allow students to effectively complete tasks and course objectives and develop skills. So some examples of common accommodations that we often see is, for example, a quiet, distraction-free room to write tests or exams, the ability to have a bit of extra time to write tests and exams, recording of lectures, or use of assistive technology. And you can see in the illustration there, sort of the accommodation to allow people to write on the chalkboard is just giving props to people so that they are able to complete that task. Accommodations do not require post-secondary institutions to lower academic or non-academic standards. The student has the responsibility to meet the essential skills and competencies expected by all students in the program. So some accommodations that would not be considered reasonable would be if it poses a direct threat to the health and safety of others, if it requires or results a substantial change from an element of the curriculum, if it requires substantial alterations into educational opportunities, or if it results in undue financial hardship for the institution, which is quite a high bar to claim undue financial hardship. So there have been barriers noted in health education regarding accommodations for nursing and psychiatric nursing students who self-identify with disabilities. One of the main barriers includes experiences of stigma and discrimination, also known as ableism. So ableism has been long reported in nursing education. A systematic review by Horkey in 2019 found that nursing students with disabilities experience strict stigma and discrimination in their education, and that ableism is often the result of a lack of knowledge or experience working with people with disabilities. And a problem with ableism is it discourages people or prevents people with disabilities from entering health education or completing health education, such as nursing. In addition, there's been identified a lack of knowledge regarding accommodation processes in health education, and that our accommodations rely on self-disclosure to access accommodations and other supports, which is perceived as a barrier, again, considering ableism that is often experienced. Furthermore, standard accommodation models don't consider unique challenges associated with health education, such as clinical and practicum placements. So we're somewhat unique in nursing and other health programs. So our team conducted mixed method research. The purpose of the study was to identify practices that contribute to the inclusion of nursing and psychiatric nursing students who experience disabilities in post-secondary education. Data were collected through anonymous online surveys using SurveyMonkey. The survey consisted of a combination of fixed response questions and open-ended questions that focused on campus resources, accommodations, and participant perceptions. We did receive a lot of data, so we're focusing here on the accommodation and participant perception piece. Convenient sampling was used to recruit nursing and psychiatric nursing students and faculty at 4 academic institutions in Canada: Brennan University, MacEwan University, Douglas College, and the University of Saskatchewan. We selected these 4 institutions because they all offer both post-secondary education in nursing as well as psychiatric nursing. So there are 4 institutions with both degree programs. Faculty employed in nursing and psychiatric nursing were invited to participate, as well as accessibility service professionals who also support students in nursing or psychiatric nursing programs. Students needed to be in year 2, 3, or 4 to participate in the survey. A parallel mixed analysis approach was used, whereby the qualitative and quantitative data were analyzed independently, and the findings were integrated once the analysis of each data set was complete. Descriptive statistics were used to describe and synthesize the quantitative data, and thematic analysis was used for qualitative data analysis, which involved coding to determine meaningful themes. Once the analysis of the quantitative and qualitative data were complete, they were compared alongside, and the results were integrated into written narratives for our final themes. So we had a total of 95 responses that were included in the analysis. So 95 participants completed our survey. Participants included 21 nursing students, 22 psychiatric nursing students, along with 49 nursing faculty and psychiatric nursing faculty, and 3 accessibility professionals. A total of 29 participants self-identified as having a disability. Of these, 19 were students and 10 were faculty or accessibility professionals. As only 3 of our participants were accessibility professionals, the data from these participants were pooled with the data from the academic faculty. In addition, we were unable to determine significant differences between our nursing and psychiatric nursing students, as we had just over 20 in each sample. Therefore, both groups were combined for a single student group used for analysis. So what did we find? We identified 2 main themes that we'll talk about here today: accommodations, as well as attitudes towards nursing and psychiatric nursing students with disabilities. And I'll talk about each sub-theme as we go through in more detail. So the first theme is accommodations. A total of 17 participants, about 40% indicated that they had accessed accommodations. So these are our student participants. Of all participants, of these, all participants received accommodations in the classroom, and 7 participants also received additional accommodations in the lab or clinical setting. The most frequent type of accommodations received included extra time and the ability to complete tests, quizzes, and exams in a quiet setting, recording of lectures, use of assistive technology. Lab and clinical accommodations reported involved additional time to practice skills in the lab, the ability to prepare for clinical in advance, extra time or extended breaks in clinical, and protected time to review charts in a quiet setting, as well as use of assistive technology and the presence of a service animal in a clinical setting. The majority of students who received accommodations reported that they were able to communicate their needs with accessibility professionals and were able to communicate their needs with their faculty members in theory and clinical settings, including having support from instructors and preceptors. Participants reported that most instructors were willing to provide accommodations, with 86% of instructors willing to provide accommodations. We did note some barriers accessing accommodations. So these are, again, our student participants. Students who reported that they did not access accommodations, so most of them reported that it's because accommodations were not needed. However, a small number of students identified that accommodations were not offered to them. So 3 students, 4 reported that they were unable to provide the documentation required to receive accommodations. The experience of stigma was also noted, and a fear of negative outcomes if they were to access accommodations. The concerns were also echoed in the qualitative data. One participant described their reluctance to seek accommodations and stated, "The fear of disclosing a disability is there because there's a risk of someone misunderstanding and deeming that you're unfit to be a nurse." So that person was reluctant to seek accommodations related to the stigma and discrimination piece. Concerns were also expressed by faculty, as one participant stated, "Getting students to access accessibility services is difficult. There seems to be a reluctance to seek help and concern that if you do seek help, they will be judged by faculty as being unworthy and therefore try to hide their difficulties." Delays in receiving accommodations were also identified. Amongst participants who received accommodations, about 60% reported that they were able to receive the accommodations in a timely manner. However, 40% reported that there were delays in terms of waiting to receive an answer from accessibility services or answers regarding what accommodations are needed. The need to apply for accommodations each semester was also described as being a barrier. So this slide focuses on faculty participants. Amongst faculty participants a lack of education surrounding accommodations and a lack of time to provide individualized support were identified as being challenges in supporting accommodation needs. A faculty participant stated, "I've had several students with hand injuries in lab and clinical practice, and I worked with them to alter their technique. However, it's challenging to give students extra one-on-one time to problem solve and to work with their limitations, considering other demands on instructor time in clinical and lab environments." Another faculty stated, "There should be more supports available to faculty to know how to assist students. I receive accommodation letters, but that doesn't seem like enough. Accessibility services truly needs to be staffed better to help improve outcomes." In addition, 14% of faculty reported that they were unaware of what accommodations were offered or available and what types of academic supports were available to students. Barriers to clinical accommodations also was noted to be a sub-theme. So both faculty and student participants discussed barriers to clinical accommodations. Participants reported that accommodations for theory courses were easier to implement than accommodations in clinical environments. A lack of understanding of the complexity of the clinical setting was seen as a barrier for those accessibility professionals creating accommodation frameworks and models for individual students. And some participants felt that some of the accommodations noted were unrealistic given what needs to transpire in clinical practice. So one faculty participant stated, "It's challenging when accommodation services do not understand the tasks and responsibilities of a nurse within healthcare environments and attempt to support students with accommodations that are not appropriate for clinical setting nor realistic or sustainable to support in the long run." Some faculty participants also voiced concerns that lab and clinical accommodations were not preparing students for the realities of clinical practice. However, students who received accommodations reported that accommodations did help contribute to their success in classroom, lab, and clinical settings. The majority thought that accommodations helped them meet the essential requirements of the professional program and helped to prepare them for their future nursing practice. Amongst all participants, over 70% agreed that accommodations could help students meet the essential requirements of their professional program. However, only 62% of participants thought that accommodations could prepare students for their future nursing practice. Only 41 participants strongly agreed that employers can accommodate nurses and psychiatric nursing students who experience disabilities. Of significance, we noted that there was a significant difference in responses, not between students and faculty, but between those who self-identified with a disability and those who did not self-identify with a disability, having those who self-identified with a disability being more likely to agree with these statements than those who did not.
Thanks, Andrea. So I'm going to talk about the second major theme, attitudes towards nursing and psychiatric nursing students with disabilities. And as Andrea mentioned, in this section, we did 2 levels of analysis. We looked at the descriptive statistics and proportions, but we also then looked for differences between the 2 subgroups. So a lot of what we're going to talk about looks at some of the differences that actually were identified between those individuals who self-identified with a disability and those who did not. So participants were asked how strongly they agreed or disagreed with 3 statements regarding the ability of nursing and psychiatric nursing students who self-identified with a disability to meet the theory and clinical components of the professional nursing programs, and also to provide safe patient care. The majority, about 75% of participants, strongly agreed that students who self-identified with a disability could meet the theory requirements of professional programs. And only half of participants, however, self-identified or agreed that students who self-identified with a disability could meet the clinical program requirements. The majority, about 81% of participants, agreed that nursing students who had disabilities could provide safe client care. However, participants who self-identified themselves as having a disability were more likely than those who did not to agree with the statement. So support for these findings was also reflected in the qualitative remarks. While some participants commented on the ability of students who had disabilities to meet the program requirements, others expressed concerns about the ability of students with disabilities to provide safe patient care. Consistent with the quantitative findings, differences between the attitudes of participants who self-identified with disabilities and those who did not were identified. So one faculty participant who self-identified as having a disability remarked, "I think psychiatric nurses with disabilities are valuable assets and should be treated as such." While another faculty member who did not self-identify as having a disability stated, "As an instructor, I would like to know what nurse employers are willing to accommodate. I worry we're setting students up to fail in their professional practice." Participants were also asked how strongly they agreed with the statement, "Accommodations place nursing and psychiatric nursing students with disabilities at an unfair advantage over those students without disabilities." Only a small proportion of faculty, about 21%, and student participants, about 23%, strongly agreed with this statement. When comparing the responses between those who self-identified with a disability and those who did not, those who did not self-identify with a disability were more likely to agree that accommodation provided students with an unfair advantage. This finding was supported in the qualitative remarks. One student who did not identify as having a disability wrote, "Working in a hospital, those with disabilities often get easy assignments that won't challenge them like the rest of their peers." Whereas students who self-identified with disabilities recognized that many students, that this perception was prevalent among faculty and their peers, but felt that it stemmed from a lack of understanding of the added challenges they encountered. As one participant noted, it's important to realize that students identifying with disabilities often have more things on their plates or more things working against them that actually make the education system much harder for them to go through. As we often talk about it in nursing school, it isn't always about achieving equality. In some cases, such as in providing supports to those with disabilities, it's about creating equity and ensuring everyone has what they individually need to succeed, and therefore creates a fair environment. 6 questions on the survey asked participants if they had observed stigma and/or unjust or unfair treatment towards nursing and psychiatric nursing students in society, on campus, and in the clinical setting. Just over half of participants reported that they had observed stigma towards nursing students on campus and in the clinical setting, with a higher proportion, about 65%, reporting that they had observed stigma towards nursing students in society. A slightly lower proportion of participants reported observing unjust or unfair treatment in all 3 settings, with the highest proportion reported in the clinical setting at about 48%. No statistically significant differences were found between faculty and student responses. However, again, statistically significant differences were found between those participants who self-identified with a disability and those who did not. Participants who self-identified with a disability were more likely to report that they had observed stigma towards a nursing student on campus, and that they had observed unjust or unfair treatment towards a nursing student in society and in the clinical setting. Participants who self-identified with a disability provided many examples of times that they had observed ableism. As one participant stated, nursing is so behind in being accessible to all students. I understand there are physical and mental requirements with any job, but the gatekeeping I see in my colleagues often has ableist undertones. A student participant who self-identified with disability shared experiences of ableism and fears to engage in disability disclosure. They noted clinicals are difficult as you cannot tell an instructor any needs required related to your disability. If you do, they will make preconceptions and assume you cannot do the work and that you're unable to provide safe patient care. I had a clinical instructor who told me every day how disappointing I was. The discussion. So although nursing and psychiatric students who self-identified with a disability acknowledged that accommodations supported their success, challenges related to accommodation processes were noted, particularly in the clinical environment. Faculty participants expressed uncertainty about which clinical accommodations could be deemed reasonable, given the need for students to demonstrate skills and meet entry-level competencies of their nursing profession. It's echoed in the literature that nursing faculty often feel unprepared to accommodate students with disabilities in clinical settings. In addition, nursing programs often lack a developed accommodation framework for students with disabilities, which negatively impacts their success with clinical education. Experiences of stigma, discrimination, and ableism were also noted, particularly in clinical settings for students who self-identified with a disability. Negative responses from faculty and clinical instructors towards nursing students with disabilities made students reluctant to access future support and accommodations, despite the fact that those accommodations were contributing to their success. Epstein et al. Suggested strategies to better facilitate the inclusion of nursing students with disabilities in clinical placement, including things like developing a supportive network, providing reasonable accommodations, and focusing on student strengths. In addition, collaboration between faculty, students, and preceptors is required to improve student success in clinical settings. Those who experienced a disability, both faculty and students, were significantly more likely to have positive views of accommodations and the ability of students who self-identified with a disability to safely provide care. Given that ableism is often related to a lack of knowledge, improving faculty knowledge may serve to reduce the stigma and discrimination reported. To improve the success of nursing students with disabilities, nursing faculty must be knowledgeable and informed of accommodation practices. Faculty require additional education and training regarding disability rights and law to prepare them to implement accommodations nursing students with disabilities in clinical settings require. Yarbrough and Welsh found that nursing faculty were more willing to provide accommodations and adapt their practices to create more inclusive environments when they received education about accommodations and were informed of available resources. Provision of reasonable accommodations was found to contribute to the success of nursing and psychiatric nursing students with disabilities. Yet the implementation of legislated accommodations has not produced equity, nor has it challenged the dominant view of disability that aligns with the medical model where disability is viewed as a deficit. Accommodations give the illusion of equal opportunity, yet students encountered several barriers in accessing these supports. Through this process, students who self-identified with a disability are often seen as the other, and accommodations can be easily questioned. The power differential between students and faculty therefore creates barriers to self-advocacy, especially when they encountered negative attitudes. Therefore, it's important to distinguish between accommodation and accessibility. These two terms are often mistakenly used interchangeably. Accommodations are for individuals and are reactive. Accessibility is for the population and is proactive. Accessibility should make content available to all in equally effective ways at the same time. Accessibility is the attitudes, accommodation are just the tools to reach it. Based on the research findings, there is a need to change mindsets and attitudes and shift focus from the individual and look towards academic practices and norms that disadvantage nursing and psychiatric nursing students with disabilities. To align with the social model, which advocates for the removal of barriers and unnecessary obstacles, universal design emphasizes proactive design to avoid the construction of barriers rather than reactive adjustments to mediate barriers that shouldn't have been created in the first place. From the perspective of a disability and education perspective, UDL aligns with the social model of disability, where addressing access is regarded as a social responsibility. This approach recognizes that the disability is not the focus, but rather attention is on the removal of socially and environmentally imposed access barriers. An effective first step to improve accessibility is to evaluate and universally address the accommodations provided to improve access for all. This approach would serve as a starting point to improve accessibility and minimize the reliance on individual accommodation. Universal design for learning requires flexibility in approaches and materials to create environments that support learning for all without compromising the standards of the program. The onus to improve accessibility does not solely fall to the nurse faculty. Administrative support, improved resources, and improved policies and guidelines are required to improve accessibility. Academic institutions need to recruit and retain more accessibility professionals, given that the number of students with disabilities are increasing in post-secondary education. This was evident given that the majority of student participants who accessed accommodations noted long wait times to receive supports. Finally, currently, individual accommodations are necessary due to a lack of accessibility in nursing and psychiatric nursing education. Relying on accommodations to meet student needs perpetuates the misconception that students are given special treatment, reinforcing ableist attitudes. While accommodations provide support, they are only a temporary solution until accessibility in these settings is improved. Implementing universal measures to address common accommodations that are required would improve accessibility and reduce the need for students to engage in disability-related self-disclosure. Further research is needed to understand practices that foster accessibility in nursing and psychiatric programs from student and faculty perspectives, including that of accessibility professionals. There is also a need to better understand clinical accommodations in nursing and psychiatric nursing practice to inform academic processes. And that brings us to the end, and we'll open it up for questions.